Good afternoon and welcome to a session on the COVID-19 vaccine tests and treatments brought to you by the Sri Lanka Association of New York in partnership with the Sri Lanka Medical Association of North America. My name is Shamistra Nadarajah, also known as Elon Xavier Nadarajah. I am the Vice President of the Sri Lanka Association of New York, or SLANI, which is the oldest Sri Lankan association in the United States. It is an organization that was established over 50 years ago to promote the general welfare of Sri Lankans residing in the US, particularly in the tri-state areas of New York, New Jersey, and Connecticut. The Sri Lanka Medical Association of North America, or SLAMANA, was formed in 1996. It was originally formed as a non-profit, non-political organization with the sole purpose of providing charitable and humanitarian services related to healthcare in Sri Lanka. In 2009, SLAMANA extended its mission to have projects in the United States, which includes providing free health education that promotes the health and well-being of the Sri Lankan community at large. With this goal in mind, the SLAMANA president, Dr. Trikante Rajapaksa, is going to do a presentation on the COVID-19 vaccine. Following that, we will have a panel of SLAMANA members who will provide additional information regarding the various COVID testing that is available, as well as information on what you should do if you ever test positive. You can ask questions by using the question feature in Zoom, which I will pose to the panel. So without further ado, let me introduce Dr. Trikante Rajapaksa. Trika, take it away.
Thank you, Sanjeev and Shamis, for giving me this opportunity to reach out to the Sri Lanka community and friends. So we're going to start now with COVID-19 vaccines. I myself decided to volunteer for the COVID trial, Pfizer vaccine trial. Pfizer and Moderna was putting out an advertisement looking for 30,000 volunteers each. So I thought this might be a good thing for me to do. But before I decided, I had obviously questions for myself. And the questions I asked were these. Is it safe? Is this vaccine safe for me to get into the trial? How is it made? And what's the science behind it? And also, how was it produced so quickly? What are the side effects? And what is herd immunity? People were talking about herd immunity. I wanted to get an exact idea what did this mean? And what would happen if I don't take the vaccine? So here's a picture of the COVID virus, coronavirus disease 19 for 2019 virus. So this is an RNA virus. Some viruses are DNA viruses, some are RNA. Most of the viruses are really RNA virus. I'll explain to you what that is. But you see here the pink over the virus, and that's the corona. Those are the crown. That's what the crown is made of. The name corona came from crown. And these are very important. These pink things that are projecting, they're called spikes. And there is a protein within that. And that's the spike that helps this virus get into the cell of the host. Now, viruses actually cannot exist by themselves. They need to be in another cell, a living cell. They are, you could consider them to be like parasites because they just have to be in a cell, otherwise they die. After a few hours maybe, depending on the virus, they just disappear, they die, they are not viable. So you see that when somebody inhales, somebody coughs into your face, you're not wearing a mask, it goes right into your lungs. And you see what havoc it can raise in the lungs. It takes over all the activity of the cells and then just multiplies and multiplies, gets into the cell with the help of that spike And that's how it gets into the cell. Once it gets into the cell, it can multiply and then take over the heart, the lungs, the brain, the kidney, any part of the body, practically every part really. And then the normal cell function cannot occur, the cells die, but the virus multiplies, the person dies. But not everybody dies. So the World Health Organization has this disease severity index. So most of the people who get coronavirus infection, 80% of them, they get a mild illness, or they may be even asymptomatic. 15% will get severely ill, 5% will be critically ill. So the case fatality rate, that is, how many people die, how many people who got infected die. Now, in high-income countries like the US, 2% will die. In low-income countries, more than 2% will die. They don't have respirators and proper ICUs and so on. In the USA, as of 1/9/2021, there were 22 million cases and 375,000 deaths. In the world, 88 million cases and 1.9 million deaths. Now let's take the local figures. In New Jersey. This is late December. There were 206 deaths per 100,000. Now this is the highest in all the states per 100,000. You see in New York, it's only 187 per 100,000 deaths. I'm saying only because just in comparison. But because the population in New Jersey is practically half of New York, the actual deaths, the total deaths are 19,000 in New Jersey, which is less than the total deaths in New York. Now let's get to Sri Lanka. As of December 30th, these numbers are from that date. 42,700 cases and 199 deaths. This brings us to a case fatality of 0.46%. And the deaths per 100,000 as 1 compared to New Jersey, we said 206 per 100,000. So it seems to be really pretty well controlled in Sri Lanka, although, it's still, people are very worried about this in Sri Lanka. Now we come to the vaccine. Before we understand the vaccine, we really have to know a little bit about the science of it. That is the only way that you can be comfortable with the safety. How really was this vaccine made? Now, just a little bit of biology. The our cells in our body are composed of each cell of cytoplasm and a nucleus. Now, the nucleus is what contains the chromosomes. Chromosomes, we get 22 plus X from the mother and 22 plus Y or X from the father. So, and these chromosomes contain the genes. That's what makes us, each individual, different from another. So the genes are actually the DNA. The chromosomes contain the DNA, and parts of the DNA, each part of the DNA will be a gene. Each little part will be a different gene. Now, what happens with, now we are talking about this messenger RNA. Everybody's talking about this RNA. What exactly is this RNA? Now, we talked about the DNA. Now, the DNA is within the nucleus, we said, but the RNA is able to go outside of the nucleus into the cytoplasm. Why is it important for that RNA to do that? Now, the DNA is like it has the recipe, it's like a recipe book for the synthesis of proteins. Proteins is what our body is made up, really. Every hormone, enzyme, everything is a protein derivative. It's made up of, so the proteins are our whole life is really consisting of bits and bits of protein doing different cell functions. So here we are in the nucleus with the DNA. Doesn't want to release the recipe book. If the recipe book is lost, we are finished. So it finds itself, it makes itself a recipe messenger of that recipe. This is called RNA. The DNA forms an RNA, and this RNA carries this message across from the nucleus to the cytoplasm, gives this message to the cytoplasm to make protein. You see the protein has been made here. Now, when you have that spike protein, let's say, here's the spike of that virus, the COVID virus. That spike has a special kind of protein in it called the spike protein. The RNA has that recipe to make the protein. The spike is important, we said, because that's how the virus can get into the cell. And if we have no immunity, the virus will get into the cell, make more and more copies of itself and ruin the cell. And then from cell to cell, the person will get very sick. So here is this. I'm going to draw a picture of this spike. Here is the spike. This is an enlargement of this little purple thing. So within the spike, there is this messenger. The virus contains only RNA. It doesn't contain DNA. We said it is an RNA virus. So all the recipes, the genetic code is carried by this RNA. Now, how do we know this? Because this genome or the genetic pattern was worked out or was demonstrated in China. When the virus came, they immediately looked for that genomic pattern. And they published it, January 11th, they found it, they published it through the WHO and anybody. The scientists were able to access this via the internet. So they knew they didn't get the virus, they have nothing to do with the actual virus. Everything was from this genetic pattern that was on the internet. So then they put it into the software and they're able to create this RNA in the lab. So here's the RNA within the spike. So in 1961, actually, somebody was scientists were able to isolate this RNA. So, but they didn't know what to do with it. So then they eventually tried out a vaccine with this RNA for a respiratory syncytial virus in children. Actually, it didn't work. And actually there was a big reaction of inflammatory reaction. It didn't work, it was harmful. So then they thought, what can we do to modify this RNA? So somebody by the name of Carrico worked with this, and in 2005, she's Hungarian. She started working on this in 1978, but came to the University of Pennsylvania, and there she modified this RNA. This is the messenger RNA. There are a few types of RNAs, but we're talking about the messenger RNA as the main type. So what did she do? She modified it, made it like a little bit different. This probably will win the Nobel Prize because this modified RNA can get into the cell. And so that can carry with it various antigens and so on for cancer and for vaccines and stuff. It can carry something with it, carry the recipe for something. But still there was a problem because even this modified RNA got destroyed when it got to the human cell before it could get inside. So then in 2010, somebody from MIT found a way to put a lipid nanoparticle cloak on it. A cloak, this is not a good picture, so let's take this one. This is the modified RNA that got destroyed when it got into the human cell. So they found something, and this is the cloak that they found, made up of lipid nanoparticle. So now it's covered with a cloak. Now this cloak is lipid and it can melt. The Pfizer, the one that the Pfizer labs, Pfizer and BioNTech labs found, that cloak does not, that will melt if the temperature rises above minus 70 degrees Celsius. Now, minus 70 degrees Celsius, as you have read everywhere, it's very difficult to get that temperature that low. You have to have special freezers. This is a temperature below, even in the winter in the Arctic, you don't get such a low temperature. So, and the low temperature is to prevent this lipid from dissolving, like butter, but dissolves at a needs a much lower temperature to remain solid. So what happens now is this thing, when you can inject this, there are some diluents that go into the vaccine, and now it's carrying this virus part. The spike protein is being carried. The recipe for the spike protein is being carried by this cloaked RNA, and now that can get into the cell. Once it gets into the cell, the cell mechanisms that make protein thinks that this is part of the normal cell and starts making protein from this recipe together with all the other recipes that they have got naturally from their own nucleus and own RNA. So now the proteins are being made. We'll put it in blue. So the proteins are being made, and okay, so you see this in blue, this is the protein that is being made. Now, finally, the cell realizes this is some foreign protein. This is not really our own protein. So the minute the cell realizes that, immediately the immune system comes into play. These proteins are attacked by the immune cells that form to get rid of this foreign protein. So this is actually the basis of stimulating the immune system to fight the COVID virus. So once these immune cells are formed, they will get rid of all this extraneous protein. Meanwhile, that lipid capsule has melted and gone away within the cell. So nothing is left now of what you put in, except these immune cells that have now a memory of what it encountered before. So when you get another virus coming, another COVID virus coming, actual infection, suddenly immediately the immune cells realize a foreign body has come, and they will quickly multiply and get rid of this coronavirus. So it cannot make that person sick, the vaccinated person sick. So then the next question, okay, you have a little bit of the science. And I should tell you that when that messenger and everything, that's all made outside. It's nothing to do with the virus. We got the genome from China in early January 11th, I believe, where they mapped out the genome of the virus. We did not need to get the actual virus. Only the genome of that virus or genetic pattern was on the internet, and the software was created to get that recipe and then synthesize all the other things that I was talking about. They are synthetic. There is no live virus, and this is a very important thing. How come we did this so soon? Because the last vaccine, the mumps vaccine, took 4 years. That's the fastest vaccine that has been developed in this world. So how is it that this and the smallpox vaccine took about 100 years to really get the proper vaccine? And similarly, polio. So how come this came out so soon? I told you from 1961, this thing has been going on with this messenger RNA. Everybody was fascinated, but they didn't know what to do. But then later, in 2017 and so on, they were working with the Zika virus, trying to get a different Zika vaccine, trying to get a different flu vaccine, even a rabies different rabies vaccine and so on. So the platform was there, they were working, and mostly HIV. But it was slow. Why was it slow? Because people were not just pouring money into this. These things cost money to make the machines, get the personnel, and they would write for NIH grants. They'd be turned down because they thought they're wasting money with this. But then when this virus came and it was a pandemic, people started pouring money. People, meaning the government, started pouring money. So this kind of funding never happened before. And also you need volunteers. Where you get 30,000 suddenly showing up, volunteering for this vaccine, 30,000 for another, 23,000 for AstraZeneca. People don't just jump for it. You have to go looking for the people. And also the number of cases. Let's say you want to get a vaccine for Ebola, then you have to go to Africa. And then why do you need a lot of cases? Because what are you doing? You're comparing the vaccine to salt water. So if people don't get sick, people who got the vaccine don't get sick, but the saltwater people got sick, then you say, hey, the vaccine works. So you need enough people to get infected. If you do Ebola over here in the US, the vaccinated people don't get sick. The regular salt water don't get sick. So how can you say, does the vaccine work? But when there's a pandemic and so many cases in the US, for example, you have so many people that can get infected. So the vaccine protected them, the salt water didn't. And even in the US, they looked for states that had a high incidence. Federal government gave $14 billion to companies to do the best they can, as fast as they can. And it wasn't just the government, it was government and private partnership, because private people are not bogged down by all these government regulations as much. Is it safe? This is the question, everybody. Does it contain the virus? No virus. Everything is synthetic. Synthetic molecule creates a protein. As I told you, immune response gives protection. Can the vaccine cause COVID disease? No. That answer we have. It cannot cause COVID disease. Can it have other effects? We don't know 100%, but we'll come to that. But not COVID disease. Is it effective? So now, for instance, for Pfizer-BioNTech, 44,000 volunteers at 153 vaccine sites in 6 countries. So they got the data from 38,000. You'll say, why 44,000? Why did you pick 38,000? Because the FDA wanted at least 2 months to go after the second dose before you presented the findings. So some people who enrolled later, 2 months hadn't gone, so they had to be left out. Okay, so 38,000 people. Their ages were, when they first started the trial, they were from 18 years to 85 years, but then they expanded it to include from 16 upwards with no upper limit. So Pfizer, they checked from 16 upwards. So Pfizer gave 2 doses, one starting point, around 7 to 12 days, we start building the immunity. Second dose is 3 weeks later. Moderna is 4 weeks later. Pfizer is 3 weeks later, and within a week of that, you get full immunity. But they say 95% immunity is sure in 2 months, they say, after the dose. But you can be confident that you have enough immunity 1 week after the second dose. When the volunteers got the vaccine, 170 people got COVID. But most of them, 162 of them were in the placebo group. 8 were in the vaccine group. But of all people who got a very severe case of COVID, 10 people got it, only 1 was in the vaccine group. Nobody died from the vaccine. Some died of heart attacks and all, nothing to do with the vaccine. So they concluded that Pfizer-BioNTech was 95% effective, Moderna also 95%. AstraZeneca, which uses a little bit different genetic material but carried by a vector, I will come to that, 70 to 90%. One study was 70%, another study was 90%. So the difference was because of the dose they gave. There are other side effects now. This is important. Side effects most of the side effects are actually caused by that nanoparticle, lipid nanoparticle cloak, it causes some inflammation. So the common side effects are, at the injection site, pain. I had pain, quite a bit of pain, more than what I got with the flu vaccine. Some other people, like one in the panel, Dr. Nadarajah, said he had no pain at all. And but about 60 to 80% will have pain, but it goes away. You go to bed with pain, didn't even require Tylenol. I woke up the next morning, had disappeared. The pain had disappeared. You can feel fatigue, headache, muscle pain, chills, joint pain, fever. Some people in the study got fever, few people got high fever. But the good thing is, within a day, all the symptoms disappear. But you cannot say, you can't get frightened saying, oh my God, I got fever, muscle pain, maybe I got COVID. No, that is a side effect. There were 29 cases of severe allergic reaction. We call it anaphylaxis, where they feel a fullness in the throat, can't breathe. But that is easily treated with epinephrine and Benadryl. That's why people who have a history of anaphylaxis, they carry a EpiPen with them, because they know immediately when you take the injection, the symptom goes away. But people did get that. So who should not get this vaccine? Immunocompromised people, they have, I know people with kidney transplant have got the vaccine, but you have to discuss it with your doctor to see what is your individual risk for the vaccine. So the reason with transplant patients, they are on immunosuppressive drugs, so they don't reject the transplanted organ. So they are immunocompromised. People with certain diseases are immunocompromised, so that you have to discuss with your doctor. Pregnancy and lactation, also discuss with your obstetrician. If you're a frontline worker in the emergency room, you're pregnant, most likely your doctor will say, take the vaccine. Whereas if you're going to deliver in a week, which is what happened, resident in our hospital, the wife was going to deliver in a week, she's in the house, unlikely she's going to come in contact with the virus. She didn't take the vaccine. So she did not take the vaccine. So it depends on the individual case. Every patient, every person who gets a vaccine should be observed for 15 minutes. And those who have allergies, and they should be observed for longer. What are the contents of the vaccine? People who have allergies to injections and vaccines, those are high risk for the reaction to the COVID vaccine. What are the ingredients of the vaccine? Mostly salt, some carbohydrate, sucrose, some lipid, but also PEG, that's the ingredient of Miralax, that's over the counter, that's PEG. So that, but who's allergic to Miralax? But if you are, then you know that those people will have, they have to be observed for longer because they may have a reaction, because that's the content of the vaccine. So now we come to vaccine hesitancy. Some people are afraid. There are those who say, no, I'm never going to take the vaccine, but there are those, and they won't take any vaccine, measles vaccine. So even before Corona, the World Health Organization said vaccine hesitancy is a major global threat. This is for anything before Corona. So here's the first two little mice with vaccine hesitancy. Okay, now a poll was done to see how many US adults will take the vaccine. 60% of adults said they will definitely or probably take the vaccine. Now, this was released December 7th. When more and more people take, this number is going to go up. More and more people are going to want to take it. You see that the Black Americans, only 42% said that they'll take the vaccine. That's troublesome. The Black Americans have had very bad experiences with vaccines in the past. And that's why they are hesitant. They don't trust as much anything new. That's understandable. So willingness increases with income and education, but you can't say that for sure because there are lots of my colleagues who are hesitant for the same reason. Unless you go through all this, learn the science and so on, out of the blue, somebody says they want to give a vaccine that was developed within a year, you will be hesitant. So here we are now. We find that 25% of COVID deaths are in African Americans. So the most hesitant group is the ones that will suffer the most. 80% of doctors in New York State said they will take the vaccine. Now, herd immunity. So it's important not only for the individual to take the vaccine. It's important for the individual, but it's also important for the people around you. What is herd immunity? 70% have to get vaccinated to develop this, what we call herd immunity. Now here's a picture of a herd of people. Oh. So here's a herd of people that got vaccinated. So when you're vaccinated, you have a few antibodies in your system. Remember we said a memory is here. So with some antibodies, these people got vaccinated, okay? So here we are, the virus comes along, and then you breathe it in. Then the memory kicks in and the virus is killed. So that virus got killed. And remember, these viruses don't live forever. Unless they come across a cell, a human cell, eventually they'll die. So here's another virus coming along, and again, killed. Similarly, this virus. Now, this person was not vaccinated. So the virus comes along, and then that person gets sick. Either he gets very sick and he dies, or he gets sick and like the 80%, he recovers. So when he recovers, he also now developed antibodies. So all these people have antibodies, okay? These were from the vaccine. This guy is from the natural infection. So this is direct immunity. These two in the middle that got hidden by this thing band here, believe me, there are two people there. They don't get infected. Why? Because the virus got killed by all these other vaccinated people. So this is the herd immunity. These are directly immune, and those two guys are indirectly because the others around him were vaccinated. That's why it is so important that 70% of people should get vaccinated. So it's not just for you, but it's for your grandmother and also for the people, the community. Everything is not just about ourselves, right? So therefore, let me please erase this thing so that it doesn't show in the next slide. There's a way of erasing it all at once, but I don't know how. So here I am erasing the whole thing and wasting your time. Okay. So in the USA, 200 million people have to get immunized, 330 million population, 200 million people. In the world, 7.8 billion is the world population, 70% of that roughly, 5.6 billion have to be vaccinated. So like in smallpox, if everybody is vaccinated, the virus disappears. Smallpox was eradicated in 1978. Since 1980, the little children born since 1980 don't get vaccinated for smallpox. Whereas all of us have those marks from vaccination, smallpox vaccination. Now comes the availability. If there are 7 billion people, we need 14 billion doses to vaccinate the whole world. Now, this is a thing that the CDC put out a priority list. 1A, healthcare workers, nursing home resident staff. 1B, essential frontline workers, grocery store workers, and so on, and people 75 and older. 1C are people over 65 and also people over 16 who have comorbidities, like if they are 40 years old or 30 years old or 20 years old with diabetes, they will get the vaccine. Everybody else will be after that. And just for we need to note that there are 87 million essential workers, 53 million people 65 and older. So you can see that about 130, 140 million vaccines are going just to these people. And then you have to double that because everybody gets 2 doses. So this is a nice picture. So in addition to the USA, there are other parts of the world. And here we are with India. India is making 2 main vaccines. Bharat Biotech says they will make 1 billion vaccines. And then the Serum Institute of India partnering with AstraZeneca is also turning out vaccines. The price, AstraZeneca is $3 to $4 per dose, whereas Pfizer is $17.50, Moderna $25 for us in the US. The government is paying this to give us the vaccines free. Now the storage, you know that I said about the minus 70 degrees, and Pfizer in Kalamazoo, Michigan, made a whole football field size of these refrigerators, special ones to store the vaccine. They made it before they even knew that the vaccine was going to work. So there was a lot of money that was put into it. It was a gamble. Look at this now, the FedEx thing. It's GPS enabled. Thermal sensors are in it 24/7. Monitors are monitoring tower is monitoring what's happening inside this FedEx van because they don't want the vaccine temperature to go down. Pfizer, you have to put it in this freezer, and there are dry ice thermal shippers that go out to the people. Once you open this, you have to use it within 5 hours once it's at room temperature. Similarly, Moderna can be kept in the freezer, regular freezer, that is our household freezer is minus 20 Celsius. And room temperature for 12 hours, once you open it, you have to use that within 12 hours. AstraZeneca is better because you can keep it in a regular refrigerator. Now, AstraZeneca uses also genetic material, but it uses a vector, like a stealth bomber. The vector is carrying the virus part, not the actual virus, but the synthetic thing, to the host. So the vector here in AstraZeneca is a chimpanzee adenovirus vector. It doesn't cause disease in humans, only in chimpanzees. Now here's a picture of that vector. Okay, so here's our virus, COVID virus, and this is the RNA to carrying that recipe for that spike protein. Spike protein, and then that is what elicits the antibody response. Here's this vector going into the arm of the person. By the way, the cells that make this is actually the muscle. The muscle cells are making the protein and eliciting the antibody response. That's why you get a local reaction there too. Okay, here's a cell and here's the nucleus. Now the thing with this is that this vector is a DNA virus, DNA. So, and what's happening is that this DNA virus is carrying that messenger RNA, but the RNA has to be converted to DNA outside. That is some synthetic process. And that DNA now is loaded onto this is loaded onto this, a part of this DNA of the adenovirus is replaced by that RNA DNA of the COVID virus. Now it's going, the stealth bomber is going, went into the arm and went into from the cytoplasm, went into the nucleus. This nucleus has our own DNA. Now another one has come, but this DNA does not integrate with our DNA, and it's also a weakened DNA virus, the adenovirus. It does not multiply. These things have been studied in cell cultures and in animals. And for years, because they were studying this for Ebola. And actually they came out with the Ebola vaccine in July, authorized in the US. with this vector. Okay, so then again that same process. Then now the DNA gives the recipe to its own RNA. RNA goes out, makes the protein the same way like before, but that time directly the messenger RNA came. Here it had to be converted first from RNA to DNA, then here from DNA back to RNA, a little bit of a process here. Okay, so I have to get rid of eraser. Okay, we erase that. Okay, so Johnson & Johnson. Now, what did Johnson? Same principle as AstraZeneca. Using a vector, it's a vector vaccine. The vector virus is a different virus, and the same instruction to make the spike protein. And this was the one I told you was used for Ebola vaccine, approved in July 2020 in the US. So we said there are different types of vaccines, right? So we said there is the Pfizer, the Moderna, AstraZeneca in trial, and Johnson & Johnson. A whole lot of other hundreds, about 100 of vaccines are being tried out. One is Inovia, and that Inovia is one that is given intradermally. All these are given intramuscular. Now you see here I have said emergency authorization. What is that? Circumstances exist for which there is no approved adequate available alternative. And they have made sure, even in this under emergency, that the criteria met for safety, performance, and labeling. And the product is still being studied, and all the risks are not known. But how concerned are we about the disease we want to prevent? Do we know everything? No. But do we know enough? We do know enough, in my opinion. So we went through this. So emergency is such a dire condition. We have to try to stop it. This is what is available now. We don't know everything, but we know enough that we think it is safe enough to take it. And as I said, it doesn't stop here. Now I'm enrolled for 2.5 years. And they're checking how long do the antibodies last? Do I get some unknown illness? And so on and so forth. 30,000, 40,000, about 100,000 people are being followed. Is it safe? I asked, and these are the answers I gave to myself. I'm hoping that it's enough for you as well, but everybody has to make their own decision. Basically, it's a trade-off. You take a small chance with the vaccine, or are you going to take a huge chance on the disease? So I have gone a little bit over my time, but this is where I will end this talk, and we open the questions for the panel.
Thank you, Trika, for that excellent presentation. So now we're going to invite 2 additional Slamana members, Dr. Selvarani Richards and Dr. Daya Nadarajah, to join Dr. Rajapaksa for a panel Q&A session, as she just said. Dr. Nadarajah, Dr. Richards, can you all please get yourself on video? Dr. Richards? Thank you. Okay. So on registration, many of you had submitted questions for this panel, which we will address. In addition, we are continuing to get some more great questions through the online feature, and we will pose those as well to the panel. So the first question that we have, and I'm going to address this to Trika, is can we still get infected even after taking the vaccine?
So the answer to that is yes. We remember, first of all, it's 95% effective. So there's 5% walking around that could get infected. Yes. Once we get herd immunity, then the chance of infection is very low because nobody's going to get infected then. But till then, yes. You can get the infection, the virus can come in, but the immune system will fight it off. So we don't know whether there could be an asymptomatic infection or not, because for Pfizer and Moderna, we checked to see whether people get ill. Are they carrying the virus? We didn't check that. But AstraZeneca did check that because they were doing weekly COVID tests. So they knew whether the people are getting infected. Most likely people don't get infected.
Okay, thank you. Thanks, Trika. Another question, can we be carriers of the infection even if we were vaccinated?
So that is where it's similar to the first question. What if we are the 5%? Yes, we are carrying the infection too. We are carrying.
Do we still have to be careful and follow CDC protocols like wearing a mask, social distancing, etc., even after we get the vaccine?
We should till we have herd immunity and we know the virus is not around for that same reason. But because I don't know, you wouldn't know whether you are the 5% or not. And also, as soon as you get the vaccine, you don't have the immunity. So if you're very soon after the vaccine, 1 week, you can still get the virus and give it to somebody else.
Thanks, Trika. This next question goes to Dr. Richard Selva. How long after someone is exposed to the virus should they get tested so that they could get the best result?
Usually they say the exposure between 3 to 5 days is an ideal time to get tested. Sometimes it could be 7 days and sometimes 14 days because that's the period of incubation. So there is no sense if you're exposed today to get tested tomorrow. So it's the incubation period that matters.
So in other words, Selva, you're saying you should wait at least 7 days to get tested from the time of being exposed?
3 to 7 days.
3 to 7.
And then to 14 days.
Okay, thank you. And this question is another question for Selva, and it's a 3-part question. First, can you explain all the tests that are available? And then what the pros and cons of each are, and also what the accuracy of each is.
Okay, so at the present time, there are 2 tests, one for the virus testing and the other one is for antibodies. Now in the viral section, everybody would have heard about rapid testing, where you go to a parking lot and you get tested. That testing is for antigens of this viral protein. And the other one is the gold standard, which is the PCR, which is a genetic testing for polymerase chain reaction. So now the difference is if I give a comparison of say 10 mustard seeds in a bottle, and that's the protein antigen. And then the PCR, in a few minutes, there's reaction and it becomes filled up into a gallon bottle of mustard seeds. So when you test, if you have only 10 seeds, you may not reach up to the expectation of an antigen testing. You may get false negative results. Whereas that gallon container has all the pieces of this protein and it will be positive. So the PCR test is always the gold standard, and if it's positive, you're positive. In the antigen testing, if you have been exposed to the COVID and you have enough antigens, you might get a positive result, which means you have the virus. But if you get a negative result and you feel that you were exposed, or the doctor says, I think you should be tested, they will send that for PCR. So these are the 2 comparisons, and think of the mustard seed that became in no time. Nowadays, the tests are done so fast. The reason that they say it takes long is depends on the lab. The testing itself is ready in about 45 minutes. But the logistics of every lab, the number of specimens they get, they have to report to the doctors, that's that 72 hours they say is a delay. But if you're positive and your antigen test is positive, you have the virus. So that's the whole thing.
Okay. Thank you. Thank you, Dr. Richards. Okay. And I think I'm going to propose this to Dr. Nadarajah or Trika. Does a positive result mean that you're still contagious even 2 weeks after first showing symptoms on the PCR test?
It seems to be that people may continue to remain positive even after 2 weeks. As to whether or not they're infectious is not, the thinking is that after 2 weeks lapses since you had your symptoms, you are not at risk of transmitting the virus. So even though you may turn to have a positive result, whether it's because of fragments of the DNA or the RNA are hanging around and dead viruses, that may be why somebody continues to be positive and the risk is not there. So the general recommendation is after 2 weeks, a person should be able to go back to work. You still continue to take the precautions. Now, there are some people who have severe disease that are viremic, where they end up in an intensive care unit. They have a large amount of virus circulating in their body. Those people are probably at a higher risk, and we recommend that we wait 30 days and we don't really test them again after that. But that's the understanding at this point.
Okay, thank you, Daya. Next question for Trika. What is your comfort and or concerns for vaccines developed using RNA technology?
With RNA technology, really, I don't have a concern about the disease. Now, with any genetic, any immune response, can you get immunity developed to your own body cells? There is a possibility of autoimmune illness. It has not been demonstrated in any kind of testing so far. And it may not happen, but we don't know till years pass and months pass what will happen with any vaccine that possibility exists. So my answer for myself is no, I have no concern that should override the fear of the disease.
Thank you, Trika. Our next question is for Daya. What should one do if you suspect you have COVID or showing symptoms of COVID?
So the important thing is that you basically take the precautions that you always do. As Trika had mentioned, 80% of the patients, people who contract the virus, have very little in the way of symptoms, and a significant number of people who have the virus actually do not exhibit any kind of symptoms. So that is where we're dealing with, because you see people coming into the hospital who have no history of exposure to anybody that has been sick, but it means that these people are getting virus through asymptomatic carriers. Once you get the virus, recommendations are that you basically take the usual precautions. There's been recommendations of taking vitamin C, zinc, vitamin D, and make sure you're hydrated. Tylenol if you have a fever, and majority of the people will get better on their own. On the other hand, if you start developing symptoms such as a cough, shortness of breath, and any other unusual symptoms like a rash or something else, or headaches, that may be an indication that you need to take further precautions or further investigation. If you have a fever, again, that's something that tends to indicate that you're getting more of a serious infection, which requires further intervention, and you need to get in touch with your healthcare provider. There is some value to getting a pulse oximeter, which checks your oxygen level, but majority of the people don't need that. I mean, if you just basically having a runny nose or some just mild symptoms, you don't need to go out there and rush and get a pulse oximeter. Anybody can purchase it for about $30 at the local pharmacy. But if you start developing symptoms of shortness of breath, or cough, or when you're walking around, you feel you're not having a usual symptom, and reassure yourself, maybe then you should get yourself a pulse oximeter. And anybody who has an oxygen level saturation above 95% could continue to just manage themselves at home. But once you start going below that number, then it is important that you seek medical advice.
Thank you, Daya. So in other words, if you have a pulse oximeter, when should one consider going to the emergency room? What should your oxygen
Once
saturation?
your oxygen level drops below 95%, I mean, if you get below 90, then there is an indication that you are developing significant or severe lung involvement. And majority of the people do not get pulmonary involvement, as we indicated, but once you start getting into a situation where oxygen level drops below 95 and then below 90, then that indicates that you really need to get yourself to the hospital.
Okay. Thank you, Daya. Next question is for Selva. What is the best and fastest way to get tested?
I think depends on which state you live. If you go to the internet, you can find a link for all the testing sites. So most of them, if you go to some places, they might say we have to send it for PCR, which takes 48 to 72 hours. But if a person feels they've been exposed to somebody with COVID and they want a rapid test, they can do the antigen test. And if it's positive, they know they have the disease. If it's negative, it may be false negative and they have to follow up with PCR. And once again, PCR is that in a few minutes, the virus can be replicated to produce millions of copies. So you'll never get a false negative with a PCR. So that's what I would suggest, because New Jersey has different links and New York has different links. So you can tell the person to click onto them and find the locations.
So Selva, in other words, you're saying that a PCR, you will never get a false negative. So if you're positive with a PCR, that means you're certainly positive.
Yes.
Whereas with the other one, the rapid testing, you could get a false negative. So you have to still be careful.
That is correct. Right?
Okay, thank you. This one is for Daya. What type of post-COVID care is necessary for full recovery?
So it all depends on the severity of the illness. Obviously, if you just have mild symptoms, you really don't need any kind of major intervention. You can just, it'll be like a cold or a flu type of symptom. It's like congestion, whatnot. You really don't need any further rehabilitation. But if you are one of the few people, 5% or so, that end up with severe disease, then there are multiple complications. Obviously, the lung being the primary involvement, but there are people who end up with vascular disease, risk of a cardiomyopathy where the heart can get affected, and neurological sequelae, and embolic diseases where they get blood clots. Those people have a significant morbidity, and they can take up to 6 months or maybe longer. We still don't know what the final outcome would be. If somebody ends up in the intensive care unit on a respirator, you're talking about maybe years, months to years. I mean, they do develop severe weakness and so on and so forth. So the idea would be primarily is to prevent it, and that's where the vaccine is a game changer, because once you get vaccinated, we can prevent these catastrophic illnesses that we are seeing in the intensive care unit, which are getting overrun at this point.
Thank you, Daya. Trika, for you, what age is the vaccine approved for? And then when can we expect a vaccine for infants and kids?
So the Pfizer vaccine is approved for over 16-year-olds. Moderna tested only above 18. Studies are being conducted for children 12 to 16, and maybe eventually for younger children too. But right now, 16 with Pfizer and 18 with Moderna, and we don't know the age only when it's the FDA here discusses AstraZeneca. They will come to answer to that.
Okay, thank you, Trika. Another one for you. How long does immunity from the vaccine last? And does the vaccine cover all known strains of the virus? Because we are hearing about all these new strains coming from England and South Africa and so on. So do you think that this vaccine will cover those strains as well?
Well, the immunity so far, 3 months, we know we have followed for 3 months. It's lasting 3 months. It will be followed, the antibody level in the study subjects. As for the variants, the genome or the genetic map of the variants are being studied. So far, the variants, the vaccine covers those variants. and the variants have a different infectivity rate, but so far they have not affected the disease severity. The one from South Africa is newer, that's being studied as well, the genetic pattern, to see is it a mutant that will affect the vaccine efficacy. So far, no.
Okay, thank you. Thank you, Trika. So Daya, I'm going to ask you a follow-up question regarding the, what do you think is the difference? What have you seen with your patients with the difference between the vaccine, the strain that's coming from the UK versus what we already had in the US? And should you be concerned from a treatment perspective? Are you concerned about that?
Fortunately, we have not seen the UK variant in this area. I think there was a report in New York and Denver, Colorado. So as far as I can see, the treatment is not going to change. The infectivity is the main concern, that there may be a higher incidence of infection and therefore more severe illness. But the virus itself, I don't think is going to make a difference as to whether you get the infection from a highly infectious or less infectious virus. It's the same scenario. So maybe we'll have more cases, but the case severity, I think it will be the same.
Thank you. That's good to know. Trika, another one. Does the Pfizer vaccine affect fertility in women? And if so, do you know how they'll be affected?
There's no evidence for an effect on fertility at this point. So the answer is no, as far as we know. It didn't affect animals. So, but when we did the study, we had to be sure that the people of an age that could get pregnant, they had to use birth control means, because they did not want pregnant people. But that's a different issue. But as for fertility, we don't have the results. There's one point that I want to really make about that people getting infected even after the vaccine. And I want to reiterate that it's not, for 90% the vaccine is effective, but I don't think I made it clear that yes, there is a period before you develop the immunity. So if you do come across that and you don't have the immunity, then you will get infected. That's why the mask wearing and all has to continue till herd immunity develops. Then at that point, we don't need masks or anything, because the virus is going to eventually reduce to such an extent and eventually disappear.
Thanks. And a follow-up question. If you already got COVID-19, should they still get the vaccine?
Yes, because we don't know for how long that natural infection, how long will it protect you? Also, whether the antibody level is enough to prevent a second attack. With the vaccine, the antibody level is very high, higher than what you get from the natural infection. So yes, they should get the vaccine.
Okay, thanks. This one's for Daya. Should I postpone surgery and avoid going to the hospital until this is all over?
Originally, when we had the first wave, it was felt that we needed to actually cut down on the surgeries and the patients who are coming in for elective procedures. That was partly because we did not have as many respirators, and we felt that we needed to be proactive in having adequate emergency equipment to treat the patients. The other issue was testing. Testing was not widely available, and we really did not test a lot of people that were coming in. At this point, we're at a level where we are able to identify patients who are sick with the COVID virus, and they also get screened and quarantined prior to any elective procedure. But obviously, it's up to the individual as to how they want to go ahead and do it. If you have something that's life-threatening, you certainly wouldn't, avoid going to the hospital. If there is something that is cancer or some other issue where that needs to be dealt with in a timely fashion, you should go for it. But if it's a routine elective procedure, knee replacement or skin lesion that needs, something that really doesn't require any kind of emergency treatment, I think it's up to the individual. So they really, I mean, most places are now equipped to screen and make sure that they are not exposing the patients to unnecessary risk. And obviously they don't want the providers to be exposed to unnecessary risk. So there is adequate protection at this point and diagnostic ability to screen out the people that are infected.
Okay, thank you. This one is for Selva. If I need a blood transfusion, how can I be assured that the blood is COVID-free?
At the present time, there is no international standards for making red cells safe. So we depend on the donors when they come for donation. We always ask them, have you been exposed? This is an additional question. Have you been exposed to people with COVID? Have you had fever? Have you had cough, cold? And then we ask them to self-defer. And for the past 28 days is our question. Then if they say they have no symptoms and they donate blood, then we tell them that they have to report to the center where they donated if they get any symptoms, fever, anybody that they exposed, or they had a test done and they got a result after the donation. So right now we depend on donor deferral. However, there's another arm to this, is that we encourage patients or people who have been exposed to COVID or had COVID and recovered to donate their plasma. We call that convalescent plasma. And they use that again under EUA, as Dr. Rajapaksa explained, emergency use authorization. And we use that to treat patients. And I think, I don't know whether Daya has experience, but we at Harlem, we do use that. And that is patients who have had COVID, now they're symptom-free for 28 days. We get their blood, remove the red cells, the platelets, and keep the plasma, test it for antibody level. If it's anything more than 101 to 250 titer, we mark it as convalescent plasma and we freeze it, and they do use that in the hospitals. So the getting COVID from a red cell donation is still not known, but they have seen vertical transmission between mother and baby. So these are all up in there, but as of now, they have had no reports of COVID infection post-transfusion.
Okay, all right, thank you. The next question is, again for Daya. How often should I get tested for COVID? Because you see New York and Selva, New York keeps saying test, often. How often should you test?
Again, this is something up for, it's not clear as to how often. I think the problem that I think we're dealing with is there's such high incidence of asymptomatic transmission of the virus that in effect, everybody should be tested at the same time, and then you isolate the people that are infected or positive would be the only way to control it. But unfortunately, we don't have the capability to do that and the rapidity with which you can identify the patients. So it's, I think, New York State recommends testing as often as you want, but that if everybody goes through that the way of thinking, it really doesn't, it's not going to be a practical solution. On the other hand, if you are symptomatic, I would say then you should be tested to make sure, but you could be negative one day and be positive the next day. So it just, and it depends on the window as to how long, like Trikante had said, it may be up to 5 to 7 days before you start to show symptoms, up to 10 days, or maybe even 14 days by the time you incubate the virus and show up with symptoms. So it's a tough decision, but I think it has to be individualized at this point.
Okay, thank you. Daya, can you elaborate quick, a couple of seconds about what the different treatment modalities are available for the various stages of COVID? So what, if you're an outpatient versus once you get it to be an inpatient?
Yeah, I mean, things have evolved over the last few months. I mean, early on, there was a push to start patients on Plaquenil, which has been around for a long time as a potential treatment. And over with multiple other studies that have come out, it really hasn't panned out. So as I said, 80% of the people really don't need any kind of treatment except just the usual things that everybody's doing at this point. But once you start developing symptoms, then obviously you want to be concerned about if the person has some sort of a secondary bacterial infection or viral or atypical infections. Going on an antibiotic may help. But once you start to have more progressive disease, then, like Selva mentioned, convalescent plasma was being utilized, but initially we were using it in patients who are in the intensive care unit, who are on respirators on 100% oxygen, and these people did not do well. So the virus is one thing, but the inflammatory response, which is a cytokine response from the body, which overwhelms the whole body, is the thing that seems to cause further damage to the body. So if we can stop that at an earlier stage, then you don't progress to severe disease. The other options that have been available have been the monoclonal antibody. Now, this is an antibody that's developed against the virus that should be taken or given within before 10 days of testing positive, and within maybe a few days after testing positive if you're symptomatic. Then those people, and if you're over BMI of 35, body mass index, they seem to be at the higher risk of developing complications. So those people, the monoclonal antibody is a good option to try to get it done. It's an outpatient procedure. Most hospitals are starting to give it. And you just go in, you're infused the monoclonal antibody, and then you're sent home. So that is a way to prevent further progression. And then once you get into the hospital, remdesivir has been available for some time. There's mixed data. That drug has some decrease in the duration of the illness. They recover faster, but not prevent mortality, people from dying from it. So, and then the steroids, Decadron, which we've been using for a long time, seems to be the only medication that will cut down the incidence of complications and death. So those are the main things. And there are other options that are still being looked at. IL-6 inhibitors, which we were using early on. Now there may be New England Journal and New York Times actually just had an article about the benefit of combining that with remdesivir as an option. But again, we're talking about really sick patients.
Okay, thank you. Thanks, Daya. I know we're running over, but we keep getting a lot of questions. We're going to go on for another 5 minutes or so. There's another question that I'm going to pose for Trika. There are fears and suspicions and prejudices associated with the vaccine within communities. What would you suggest would be a good education program or outreach to counter such fears?
I think that I told you the reason why they have this, because of the past experience of these various groups. I feel that the best way is to have seminars like this, where people can discuss it with the panelists, and also when going out into the community. For example, I met with a family council group at the nursing home and speaking to people the normal way, like you speak to people. I was listening to a doctor who was addressing the nursing home staff. He just bombarded them with, like, do you have to do this? That doesn't work with people, because they have to be, just like you. They're making the same decision you're making. So I feel that the way you present it to the people and being honest with the people, and also discussing the side effects that can happen, that will carry weight. But how are you going to recruit people to, and also the prominent people, like the president's vice president, taking the injection, then people get confidence too. Because if they can take it, then maybe we can take it too.
Thank you. And I just, I think it's important for everyone on this call to know that all three of our panelists have taken the vaccine. I know Daya took his second shot, and I know Trika, because you were in the clinical trial, you've taken both as well, correct? And Selva, you've had the one, and you'll be getting the second shot, the second booster shortly. Is that correct?
Yes, I'm getting mine on the 12th.
And as for me, even though I was in the study, it turned out that I had gotten the placebo. So then they opened it and I got the vaccine now.
Okay, great. Thank you.
Yes, Shami, but if we need to, we can go a little bit over because I know we have a bunch of questions actually on the Q&A panel as well.
Okay, all right. So if that's okay, I'm going to go into that. Okay, here's a question. The vaccine does not prevent the disease, and does it reduce the severity of the disease?
Is that for me?
Yeah, Trika.
Yeah, it definitely reduces the severity. There is no question about that, because when you saw those results that came out, the people who got the severe disease were in the placebo group, except one. What was the other part of the question?
Does it reduce the severity of the disease, taking the vaccine?
Yeah, it does reduce the severity. There was another part to it.
No, that was it. That was all it was. The next question is it, and I'm going to ask this of Trika, is it okay to take the vaccine after being found to have COVID? I know you answered that, but how long do you need to wait before you, from the time of recovery before taking the vaccine?
They say to wait maybe a week or two. You could wait 3 months because you may have the antibody for that long that protects you, but there's no sense waiting for the 3 months. When it's available to you, you should take it. But a week or two, you definitely have enough antibodies that you can stave off another attack of COVID.
Selva, this one's for you. Is a saliva specimen as effective in testing for COVID as the nasopharyngeal specimen?
Yeah, saliva testing, as you know, is much easier for everyone to collect, including kids in school. So the way they collect, even for the nasopharyngeal, the pros and cons are how well is it collected. If the nasopharyngeal swab is not turned in your nose and collected properly, the problem will be there. Saliva is as good to do the test, and they do the PCR on the saliva.
Okay, thank you. This would be for any one of the panelists. What do you suggest for people over 80? Regarding the vaccine, it wasn't clear on the question.
Can I answer that?
Yes, Trika.
Definitely, it is indicated for people over 80. There are people, older people, the majority of deaths that happened was over people over 75. That's why they fall into that category of 1B, over 75. So 80, 90, it's okay if you should get it actually.
In England, I think they have started vaccinations over 90 years of age as the starting point, and obviously they're working down. So it's a matter of priority as to who gets vaccinated, and I think any age is fine. I mean, the older, the higher the risk. So like Trika said, I think that's a good option.
Thank you. Here's another question. I think maybe Trika can hopefully answer this. Indications are that children are more susceptible to the new variant virus. Does this mean that children get more severe disease, or does it just mean that children are more likely to get infected?
As far as the second part, the children do not get more severe disease. We know that children have gotten sick, but compared to adults, they don't. The other part about them being more susceptible, I'm not certain of this.
Okay. All right. Here's another question. How is the immunity gained different from getting the infection versus taking the vaccination? Are they the same? So if you take the vaccine or get infected, is it the same immunity?
No, no, it isn't, because as I said, you get a much higher antibody level with the vaccine. That's established.
Okay. This one is for the panel. Anyone? Is there a risk in getting COVID-19 from food?
No. The answer is
yeah, thank you. What kind of long-term disabilities have you seen after recovery? I think, Daya, you went through some of those already. So I think I'm going to, no matter, I know you answer. I'm just reading.
Yeah, I mean, there are multiple things. I mean, neurocognitive issues and issues with, pulmonary and cardiac. So depending on the severity of the illness, I think is the, and then, people do end up with renal kidney failure requiring dialysis. But these are extreme cases. Obviously, the more complications you have, the longer and then more issues you have to deal with.
Okay. Here's another one. If you're meeting with family not in your direct household, should you be taking a test even if you have no symptoms?
You're going for Thanksgiving to a family gathering?
Right. Yeah, or coming up Martin Luther King, but next weekend, a long weekend. Should you be tested before you meet?
It's a good idea. I don't know how the other panelists feel. Do you agree, other panelists? If it's a group,
I think the important thing is taking measures to prevent the transmission, distancing, masking, hand washing. I think those are the most important things. I mean, obviously, if you're symptomatic, then you should definitely get tested. But if you're asymptomatic, I think it's going to be, or if you've been in an area that you were exposed to somebody with the virus, then certainly I would, advise that person get tested. And avoiding close contact, and I guess the least is to avoid a contact at all. But if you have to gather, limit the number of people that are in an area, have the room aired enough that you don't have a high concentration of the virus that can expose multiple people to the risk.
Okay, here's another, thank you, Daya. Another question, will the vaccine affect the platelet count? Selva?
Not that I know of. We haven't had studies to show that.
Okay. Okay, this is a very long question. There's a huge challenge from frontline health workers being stretched with contract tracing. Now they're giving vaccines. If they get side effects, that's going to cut down the health workers who will administer vaccines. And how do we manage such challenges? Because they're concerned about, whether they are going to have enough healthcare workers in the front lines to even administer the vaccine.
well, if they all die, then you definitely won't have frontline workers. So you do have to protect them. Yes, maybe you can stagger the where you give the vaccine, but they need to be vaccinated. And a lot of times you don't have to. The frontline people are not giving the vaccines. There are other people who are giving the vaccines, and now with even with the pharmacies and all opening up, they could go and get the vaccine themselves. The actual administering of the vaccine, no, they're not involved. Yes, the side effects, but as I said, the side effects are not that bad, it turns out. They're not that bad that they prevent people from coming to work. And you need the healthcare workers to take care of people. If they die, then nobody's going to administer the healthcare.
Another question, can the booster be delayed until all targeted populations receive the vaccination? I think
that is what now is the thought in England. They're doing that. But remember that when the studies were given for examination by the FDA, that involved 2 doses. But so you have to weigh the fact that the virus is spreading so widely, you want to vaccinate everybody. But it has to be an effective vaccine. So what people are counting on is that their production will increase to give the second dose. Right now, we are holding the second dose in the US. We are holding the second dose. So if you would put out 15 vaccines, 15 is kept by the government, federal government, to give the second dose. So that's a question that has to be, looked at. Right now, we are giving the second dose in 3 weeks for one and 4 weeks the other one in the US. But in England, they are doing the other way.
Okay, this is the last question. This one is for Daya. Any comments on the use of ivermectin, an anti-parasitic drug, which though not approved, has been reported to be very effective in the treatment of early COVID?
Um, Again, I think the question is how well the trial was done. There have been reports. I mean, I think we had the same situation with Plaquenil and some of the other drugs that are out there. So it's hard to be sure how well, unless it's a randomized trial, to say whether it's of benefit. And I think our respiration, a lot of people are trying different drugs. There was also a question of using colchicine, which is another medication that's been around for years as a form of trying to block progression or worsening of disease. Again, these are not totally proven to be effective. So that's where we are at this time.
Okay. All right. Thank you. Sanjeev, I think we have a few more questions. Should we go on or should we end now?
Yeah, I think we can go on till 1:30. We'll make a stop at that. Just 4 more minutes. I think we can cover maybe another 3 or 4 questions if possible, if that's okay with the panelists.
Yes, absolutely.
Okay.
That'll be fine.
Okay. Can you get the virus for a second time if you already got it? I don't know if you answered.
Yes.
You can.
Yes.
Okay. This is very long. I don't think I can read it. We'll have to get back to you on that one. Okay, how long is the vaccine effective for? Someone recovering from COVID may have antibodies effective for 3 months max, you said. Then the vaccine containing higher concentration, will that be effective for a longer period?
That's what we are hoping. That's what we are hoping, and that's what we are testing. And it's being tested 2 months, 3 months, 6 months, and so on. Answer is not certain.
Okay.
Hopefully it will be better than the flu vaccine, and we may not need one every year, or maybe we can get a booster, but answer is not yet known.
Okay, so there's a couple of questions regarding the content of the vaccine, and I'm going to put them together. One was whether it it has aluminum, and then the other one was whether it includes sulfur. So does the vaccine have aluminum and sulfur?
Now, aluminum I have not seen, and if you go to the drug, if you Google the drug, all the ingredients are listed the vaccine. Pfizer, for example, I did not see aluminum. I don't think it's there. Sucrose, some lipids, and as I said, PEG, polyethylene glycol, are the ones that stick out in my mind. The sulfate that you mentioned, the particular sulfate, what was the name of that sulfate they're asking?
It just said sulfur. That's all it said.
Sulfur, I didn't see anything that sulfur in the form of sulfate, I guess, but this is very easily accessible online. What if you Google what does the vaccine, Pfizer vaccine contain, it will come up.
Okay, thank you. And this is one for Sri Lankan culture. What is your perspective about medicines like Kottamalli and other Ayurvedic medical stuff from Sri Lanka?
So it's being studied, as you know, the famous thing in Kegol, the penny, the honey that is being sold at the price of 6,500 rupees, which is about $30. So the line is extending from Kegol to Polgahaval, I understand. And it contains also maybe Kottamalli, but also ginger, garlic, and curry powder, and so on. And then people said, why don't you eat a chicken curry instead of paying the 6,500 for the medicine? But the government Sri Lanka government is researching this concoction. There is no scientific basis for this. So I can't even imagine that it would be scientifically proven that this honey works. So at this moment, absolutely no indication to take it.
Okay, I know there was another question that had come up about vitamin C, and I know, Daya, you mentioned it, about taking vitamin C, D, and zinc to boost your immune system. The question is, why is that not being talked about as much by governments and CDC? Daya, do you want to take that one?
I think part of it is that there's no real control studies that have been done for people taking the, they've been around for so long that it's just a thing that has been tried out. Nobody's going to do a study where you have people just taking these and others who don't take it. Same goes for aspirin and Townhall. These are things that are available. And as long as you don't have any complications, or patients don't use mega doses and overdose themselves, I think that should be something that is cheap and available. So it's not going to hurt people.
You're recommending that people take vitamin C, D, and zinc?
Yeah, that's generally what. There's also a question of using statins, which are used for cholesterol lowering. There's some reports that maybe that is of some benefit. We've not done that. People who are already on a statin continue to be on it. So there are some reports that there may be some benefits to some of these other options.
Okay, so thank you, Daya. So this is the last question because of the time. And I think these are the questions that came through. If the effectiveness period is limited or shorter, how will we ever achieve herd immunity with the expected population being vaccinated within the effectiveness period? Trika.
We don't know that this is so short. We don't know that this is so short. It could be longer, but we have to deal with the facts that are known, and we are hoping that it will be longer. And if we need a second dose in a year, we just have to deal with that. We'll need a second dose.
All right, thank you so much. So on behalf of the President of SLANI, Mr. Sanjeev Silva, who without his support, we would not have been able to achieve all of the technological aspects of this webinar, and the committee, we would like to thank the panelists for your participation. Thank you, panel, it was excellent. And we also want to thank each and every one of you for attending this webinar. We hope you found it to be informative. Please continue to wear a mask, wash your hands frequently, and practice social distancing. And most of all, be safe. Thank you.